Hello, everyone.
Oh, yes, now we can hear you, Dr. Nader.
All right, sorry about that. So
No,
basically, today we're going to talk about rheumatology, and then we will talk about different other topics, including artificial intelligence, and we'll go over the basics of another tool for statistics. It's called R tool. We're going to go over that in a little bit. But welcome, everyone. And I think we will have two speakers for the first topic in the agenda. That would be rheumatology in older adults. When you are ready, we can share the screen. While we are doing that, we can talk about the interview skills. So we will be waiting for Sumi. She is one of the fellows that match and start with her residency. So we'll listen to her and see she can share some of the tips regarding the interview in the coming weeks for you guys. Hopefully, we will get a lot of interviews. So if the speakers are ready, let me share or they can share the screen.
Hello, good afternoon. My name is Sobia Mansoor, and today I'll be presenting rheumatology topic. And with me, Ashwini would accompany me. So let me know if you guys can see my screen.
Yes, we can see.
Yes, we can see.
Yes, we can see.
Okay. Okay, so we'll be discussing the clinical presentation of rheumatological diseases and the components and the thorough physical examination findings, how to differentiate between different rheumatological diseases and their evidence-based management. So the topics we'll be covering are osteoarthritis, rheumatoid arthritis, gout, calcium pyrophosphate deposition disease, polymyalgia rheumatica, giant cell arthritis, also known as temporal arthritis, SLE, Sjogren's syndrome, polymyositis, dermatomyositis, and fibromyalgia. So beginning with osteoarthritis. So it is a principal cause of knee, hip, and back pain in older adults and most common source of a chronic pain. Avoid the reflexive conclusion that all joint pain in older adults is a result of osteoarthritis, because there are so many diseases, as I mentioned earlier, rheumatoid, Sjogren's, and a lot of other diseases. So you can't just conclude anyone older having chronic pain is having osteoarthritis. It can be developed in any joint that has suffered injury or other disease. And the hallmark is the cartilage degeneration, but not purely a degenerative disease. There is subchondral bone abnormalities. Focal synovial inflammation is also seen in pathologic specimens. The differentials are inflammatory and crystal arthritis, septic arthritis, bone pain due to malignancy. There is bony enlargement and crepitus, so that suggests the patient is having osteoarthritis. In fingers, you would see bony enlargements in the distal phalangeal joints and proximal. And for the distal, we call them Heberden nodes. And for the proximal interphalangeal joints, we call them Bouchard nodes. The osteophytes are the radiographic counterpart of this enlargement, and asymmetric joint space narrowing is also very common in osteoarthritis. There will be joint tenderness.
So, excuse me. I think we are looking at the different slide, or not the presentation slide. Can you share the other? You can unshare and then share the slide that you are moving.
Okay. Is it fine now?
Yes.
Okay. So joint tenderness and warmth may appear, and but the true synovitis suggests an alternative or concomitant diagnosis. Advanced imaging studies are generally not indicated for osteoarthritis. Um, Here you can see the picture. There is joint space narrowing here, and here are the osteophytes and the joint space narrowing too. Then the management includes weight reduction for knee, hip, or spine osteoarthritis. You can use thermal agents for hand, knee, or hip osteoarthritis. You can ask for physical activity, and the assistive devices includes jar or bottle openers, walking aids, braces, insoles. Now, the physical activity for osteoarthritis. So CDC and Arthritis Foundation recommendations to improve the pain and functioning in patients with osteoarthritis. They suggest a minimum of 150 minutes, that is 2.5 hours of moderate intensity aerobic exercise per week, with 2 days of muscle strengthening exercises per week. So these guidelines do not apply specifically to older adults. Anyone, even younger adults having osteoarthritis, can do these and can get the benefit. A multimodal interdisciplinary approach, including referral to physical and occupational therapy, is the key in management of chronic pain related to osteoarthritis. So here comes the medications for osteoarthritis. So the traditional approach is around the clock acetaminophen, but according to the recent evidence, this therapy is not as effective as previously thought. The topical therapies like analgesic balms, capsaicin, topical NSAIDs can be helpful in hand or knee osteoarthritis. You can also consider low-dose opioids for patients who do not respond to other options. Limit to those whose quality of life is significantly impacted by pain. As well as glucosamine and chondroitin sulfate. There is conflicting data for knee osteoarthritis because they say there has been no proven benefit when we compare it to a placebo. Then there is duloxetine, which may be tried as an adjunct for chronic pain associated with osteoarthritis. As well as we have some intra-articular injections available. So the reasonable treatment option for knee osteoarthritis, they provide short-term relief that is superior to placebo, and data supporting long-term relief are limited. For hip osteoarthritis, they provide only temporary relief compared with the placebo. There is one other option, hyaluronic acid and hyaluron polymers given in a series of weekly injections in the knee. These have also been not shown any more effective benefit as compared to placebo. So there are a few surgical options for osteoarthritis. So we consider for patients who have advanced refractory osteoarthritis, have a clearly impaired function and reduced quality of life, and are motivated about post-surgical rehab. So only for these patients, we would go for surgical options. So it can be arthroscopic debridement for knee osteoarthritis. And as I said, it's only for patients who have been not gaining any, who have like impaired function and have reduced quality of life. And with patients who report mechanical symptoms, like they would present with locking of knee and weakness. So their effectiveness has not been proved, and the initial treatment with physical therapy has similar outcomes. So when you go for physical therapy alone or for the arthroscopic debridement, the results are similar. Then you have an option, total joint arthroplasty, which is considered in patients with more extensive disabling knee or hip osteoarthritis. Okay, then is the topic rheumatoid arthritis. It is an inflammatory arthritis linked to increased risk of cardiovascular disease and premature death. Most older adults with late onset rheumatoid arthritis present similarly to younger adults. There are two presentations which are unique to the older adults. One is RS3PE syndrome, which is known as remitting seronegative symmetrical synovitis with pitting edema, and it accounts for 10% of the late onset cases. The other one is acute onset seronegative inflammatory arthritis of the shoulder and hips, and it can be difficult to distinguish from polymyalgia rheumatica, and it accounts for 25% of the late onset rheumatoid arthritis. So for diagnosis, compared with the younger adults, older adults more frequently present with constitutional symptoms like malaise, fever, fatigue, weight loss, in addition to the characteristic synovitis of the rheumatoid arthritis. Older adults with arthritis also more likely to have a higher initial ESR. You have to check autoantibodies, including rheumatoid factor and anticyclic citrulline peptide, anti-CCP antibodies. Radiographic evaluation can also be helpful to demonstrate the erosions or the deformities that appear in more aggressive and long-standing diseases. The symptoms you will see are the pain intensity, location, duration of the morning stiffness, severity of the fatigue, and functional status. These are the symptoms you'll look for. In physical exam, you will look for number of the tender and swollen joints, evaluation of extra-articular manifestations, including rheumatoid nodules and other cutaneous manifestations. Interstitial lung disease can also be present, pleuropericardial disease, vasculitis, ocular disease, as well as neuropathy. In laboratory findings, you will look for acute phase reactants, which include ESR and CRP. And you will also look CBC, metabolic panel, liver function tests if the patient is on DMARDs already. You will do some x-rays, the radiographs periodically to assess for progression of the disease. For the management, the start treatment as soon as the diagnosis is made with the goal of achieving remission or the lowest level of disease activity possible. The initial approach to treatment should include initiation of one or more oral DMARDs, depending on the disease severity and comorbidities. In general, patients should be optimized on triple therapy with oral DMARDs before moving on to biologic treatments. So prednisone, 10 to 20 milligrams per day may be used as the primary treatment for seronegative polymyalgia-like disease and the RS3PE syndrome, which are the few of the presentations of rheumatoid arthritis in older adults. In contrast to the classic polymyalgia rheumatica, the late onset rheumatoid may not respond promptly to the low oral prednisone. In general, avoid the chronic use of prednisone because its use is associated with increased risk of infectious complications, fluid retention, and osteoporosis. So now the gout, a crystal-induced arthropathy more common in older adults than in younger adults. It is also associated with coronary cardiovascular diseases and metabolic syndrome. Incidence in postmenopausal women approaches that in men. The risk factors are the use of diuretics, niacin, aspirin, because of polypharmacy, and somebody having renal or hepatic impairment are at risk of having gout. So the presentations, it can be subacute or acute. Subacute will have smoldering oligoarthritis affecting the larger joints, whereas acute will be monoarticular incapacitating attack. So acute is because of precipitation by a trauma, an acute non-articular illness requiring hospitalization or abrupt change in uric acid concentrations. For example, somebody can have an acute attack due to dehydration, particularly after surgery or admissions for congestive heart failure and being treated with aggressive diuresis, characterized by abrupt onset of intense inflammation and pain, typically reaching maximum intensity within a day and with resolution of symptoms within a week or 10 days, even without treatment. That was for acute cases. Diagnosis requires at least one episode of swelling, pain, or tenderness in a peripheral joint or bursa with demonstration of monosodium urate crystals from synovial fluid or an aspirate or of autophus. Radiographs may show juxta-articular erosions of involved joints. An overhanging edge, that is Martel sign, helps distinguish gout from rheumatoid arthritis erosions. Increased serum uric acid plus clinical history of episodic mono or oligoarthritis, often podagra, is highly suggestive of gout. However, hyperuricemia is not uniformly present at the time of an acute gout attack, and the presence of hyperuricemia alone does not confirm the diagnosis of gout. Okay, then the lifestyle modifications for gout. You can ask for weight loss, avoidance of purine-rich foods such as shellfish, mollusks, organ meats, and full-fat dairy products. You can also ask for avoidance of alcohol, particularly beer, which is especially purine-rich, and reinforce the importance of lifestyle modifications at each follow-up visit. These changes can be difficult to implement and sustain, but can be invaluable in prevention of future attacks. So with the management, you can ask for topical therapy with ice, short-acting NSAIDs if tolerated. Particularly in patients, you will have to look for any renal impairments. Otherwise, NSAIDs won't be a good option. For monoarticular attack, intraarticular glucocorticoids, assuming septic joint has been excluded. Otherwise, you are not supposed to give glucocorticoids if there is septic arthritis. For polyarticular attack, oral glucocorticoid tapered over 5 to 10 days. Glucocorticoids may be preferable to NSAIDs for treating gout in older adults with multiple comorbidities. Low-dose colchicine is also an option, but its use is often limited by presence of the renal impairment. For the longer-term management, consider the lower uric acid lowering therapies, which includes allopurinol, febuxostat, and probenecid for patients with having more than 2 attacks in a year, evidence of tophi or erosive diseases, or CKD stage 2 or higher. So for these patients, the goal of having a uric acid level of 5 to 6 or lower, and you will have to educate the patient taking any of these drugs, because these drugs can precipitate a flare. So as the uric acid lowering therapy is titrated up, it is reasonable to use a prophylactic agent such as colchicine at dosages as low as 0.6 milligrams per day, making sure that the renal function permits you of using the colchicine drug, or low dose prednisone for several months. If the patient develops an acute gout attack while on any of these uric acid lowering therapies, he or she should continue the medication daily while adding an abortive treatment for the acute onset. Now, calcium pyrophosphate deposition disease, which is like gout and is a crystal-induced arthropathy, and is more common in older adults than younger adults. It can mimic rheumatoid arthritis, inflammatory osteoarthritis, gout, or septic arthritis. It is associated with someone having these conditions like disorders of calcium metabolism, for example, hypomagnesemia, hypophosphatemia, and hyperparathyroidism, hypothyroidism, as well as hemochromatosis. Presentations. So it can result in an acute intermittently inflammatory arthritis of the knee, hip, wrist, and metacarpophalangeal joints. Elbow, shoulder, ankle involvement is less common. It can mimic an acute gout attack, sudden onset of pain, swelling that coincide with or immediately follow an acute illness or traumatic event such as surgery. So it can look like a patient having an acute gout attack. So for diagnosis, arthrocentesis is required, which will show crystal analysis and is diagnostic and is useful to distinguish CPPD from the gout and infections. When fever is present, distinguishing CPPD from the septic arthritis is imperative, and the diagnostic arthrocentesis is indicated. Calcium pyrophosphate disease is commonly suspected by the radiographic finding of chondrocalcinosis on the plain films. It appears as a stippled or linear calcification of the articular cartilage of the knee, wrist, hip, shoulder, and symphysis pubis. So you can also see the cartilages, like here the menisci and the cartilages are have calcium deposition. So this is chondrocalcinosis in CPPD. Then the management involves intraarticular steroid injection. It can result in significant relief of the pain symptoms, may be a preferred option if only one joint is involved. Short-acting NSAIDs and oral steroids are used for patients who can tolerate them. Evidence for use of colchicine in CPPD is limited. Oral colchicine for acute flares is typically dosed 0.6 milligram every 8 to 24 hours, similar to the acute gout treatment. Colchicine can also be useful to prevent future acute episodes of calcium pyrophosphate disease, typically dosed 0.6 milligram every 12 to 24 hours. Now, polymyalgia rheumatica. Polymyalgia rheumatica is an inflammatory rheumatic disease that occurs almost exclusively in older adults, usually greater than or equal to 50 years old. Persistent pain or stiffness of bilateral upper arms, shoulders, hips, or thighs, accompanied by significant morning stiffness and constitutional symptoms like fatigue, low-grade fever, anorexia, weight loss. Approximately 15 to 20% of patients with polymyalgia rheumatica also have a giant cell arthritis, and up to 40 to 60% of patients with giant cell arthritis have symptoms of polymyalgia rheumatica. And diagnosis of one condition should prompt evaluation for the other. So you have to make sure if one presents with polymyalgia rheumatica or giant cell arthritis to look for the other one. So the criteria is age, somebody having bilateral shoulder pain or aching not explained by another etiology, and an increase in acute phase reactants like ESR and CRP with the age of 50 or more. If all three required criteria are present, the diagnosis of PMR is suggested based on a scoring system, which includes morning stiffness, which lasts for greater than 45 minutes, negative rheumatoid factor or anti-CCP antibodies, and pain or limited range of motion of the hips or absence of other joint involvement. Ultrasound finding of the unilateral or bilateral subdeltoid bursitis, biceps tenosynovitis, glenohumeral synovitis, hip synovitis, or trochanteric bursitis increases the specificity of the criteria. Diagnosis also, unlike in rheumatoid arthritis, usually no evidence of inflammatory arthritis of the small hand joints will be seen. Unlike in the inflammatory myopathies, normal muscle bulk and strength will be seen, and typically the lab findings will include an increased ESR-CRP, negative rheumatoid factor, anti-CCP antibodies, and anti-nuclear antibodies, and a normal level of muscle enzymes. These are seen to differentiate the other diseases from polymyalgia rheumatica. On plain radiographs, they should not reveal abnormalities, and the arthritis of polymyalgia rheumatica is not an erosive one. So this management, symptoms should respond dramatically and quickly within 2 weeks to prednisone about 12.5 to 25 milligrams per day. Consider rheumatoid or concomitant giant cell arthritis in patients whose response is incomplete or not sustained on prednisone. So you will look for these diseases. The duration of the treatment required varies from 12 to 18 months. Dosage reduction of steroids should be gradual with periodic monitoring of the symptom recurrence and doing the lab studies, including ESR-CRP, which can suggest a recurrence if you see an increasing pattern. Consider methotrexate as a steroid-sparing agent for patients at high risk of complications and those unable to taper the dose effectively. Now the topic giant cell arthritis, also known as temporal arthritis. It is actually a vasculitis, a granulomatous one, which involves the large and medium-sized arteries. Like polymyalgia rheumatica, a disease unique to older adults and occur almost exclusively in patients like 50 years or more, and increasing in incidence with age. So as you age, there is a more chance of getting giant cell arthritis. The overlap between polymyalgia rheumatica and giant cell arthritis is notable. Patients with polymyalgia rheumatica who have any symptoms above the neck should have a temporal artery biopsy done to evaluate for possible giant cell arthritis going on. Best known manifestation is cranial arthritis that may result in loss of vision and but may present initially with extracranial arthritis, systemic inflammatory symptoms, polymyalgia rheumatica, or any combination. Head and neck manifestations can present with headache, scalp tenderness, jaw or tongue claudications, diplopia, and prominent tender erythematous or nodular temporal arteries, which are typically pulseless. Constitutional symptoms will include fatigue, malaise, weight loss, fever is also common and may be the only manifestations. Like constitutional symptoms can be the only presentation in giant cell arthritis in few cases. There can be optic nerve failure or swelling, which portends ischemia with impending blindness that warrants immediate glucocorticoid therapy. Joint cell arthritis can present as sudden blindness with no prior systemic illness. Giant cell arthritis may present with claudication in arms, respiratory symptoms, transient ischemic attacks, stroke, peripheral neuropathies, syncope, ischemic necrosis of tongue or scalp, or rarely myocardial infarction as well. Aortic aneurysm, predominantly thoracic, is a late manifestation of giant cell arthritis, even when previously appropriately treated. So similarly, the lab findings will have increased ESR-CRP. You can see possible anemia of chronic inflammation, thrombocytosis, leukocytosis, hypoalbuminemia, and increased alkaline phosphatase. Serologic tests are generally not helpful, and temporal artery biopsy is the only test able to definitively diagnose giant cell arthritis. This is a focal and a segmental. Giant cell arthritis has a focal and segmental nature of inflammation. So there's a chance that you can miss if you perform biopsy on one particular site. So if a patient gets a negative biopsy result, so it is suggested to get a biopsy of the asymptomatic side as well to not to exclude the chance of missing giant cell arthritis. So they say a section of asymptomatic site can be obtained if the initial specimens are negative. With a so management with a positive biopsy or a convincing history and symptoms, start oral prednisone 40 to 60 mg to reduce the risk of sudden blindness. IV glucocorticoids for patients with transient or permanent vision loss, diplopia, transient ischemic attack, or stroke. Maintain the dose for at least 1 month, and treatment typically continues for 1 to 3 years. Concomitant low dose aspirin is suggested because it decreases the risk of vision loss and ischemic complications. There is a chance of relapse, and particularly when the steroids are withdrawn. So you have to monitor for the symptoms and also look into laboratory markers, the acute phase reactants, to not miss the relapse of giant cell arthritis and aortic aneurysms. Now, Ashwini would continue from here. Thank you.
Thank you so much, Sobia.
You're welcome.
For some reason, I don't see Ashwini. This is great presentation, Sobia. Really to the point, and I think it's important to know this presentation, and it's common in older patients, and surgeon or orthopedic usually they tell you need to check rule out infection of the joint if you think there is some inflammatory going on. You want to use anti-inflammatory, let's say steroid injection, you need to rule out septic arthritis and so forth. So it is important to go by stepwise approach for the safety of the patient. Excellent. So I don't see Ashwini for some reason. Maybe she's not able to join. But we can share the slides if you have it, Sophia.
Oh, sure, I'll share.
Okay.
I'm trying to contact Ashwini. Give me a second. I'll be back.
All right, no problem. So in the meantime, maybe we can talk about the fellowship so far. Anyone has any questions or any suggestions, anything that you think we can improve on, or things that are not working for you guys? You want to let me know? You can jump or raise your hand.
Yeah, I talked to, sorry for interrupting. I talked to Dr. Ashwini. She is just joining.
Okay, perfect. So I was just telling the other fellows if they have any suggestions as far as the fellowship going or any questions, can just text me, shoot me an email, or contact me on the phone or email. Thank you.
Dr. Nader, I wanted to ask, were we able to figure out something like somebody in last session mentioned about learning Spanish?
Yes, so the fellow, she is native speaker for Spanish, and she will let us know what's her availability. I don't see her today here, but if she has certain times of the week that works for most of you guys, maybe we can start with sessions as far as the basics of the use of Spanish in the medical field. So
Okay, that would be great.
Yeah, we'll keep you posted. Updated.
Thank you. Thank you.
You're welcome. Ashwini, when you are ready, you can share your screen. Welcome.
Yes, sir. 1 second. I got into some technical difficulty. Just a second, please.
No worries. If you want Sophia to share her screen, and you can follow if you have trouble.
Almost done. Yeah.
Almost, okay.
Okay, got it.
Thank you so much for taking care of it, Sophia and Ashwini.
Yeah. Okay, I'm here. Okay, so we are starting with SLE, right? So you finished GCA management, right, Sobia?
Yeah, I did.
Thank you so much. Okay, so we have systemic lupus erythematosus. It's a very rare disease for any rheumatological problem associated with it. It's an autoimmune multi-system disease that most commonly affects women of childbearing age. 20% of the cases have late onset, that's after 50 years of the age. So you might get confused with osteoarthritis, and we want to keep in mind that women who had childbearing age problems may be having SLE associated rheumatological problems. Compared with SLE in younger adults, late onset SLE shows less of a female predominance and is less commonly characterized by malar rash, photosensitivity, arthritis, nephritis, and other familiar features of SLE. This is very important. Like they may say, when I go to the sun, I have the rash. Where is the rash? On the malar area, which spares the nasolabial fold. They have it on the cheeks and a part of the nose. So that's very characteristics for SLE, and you have to have a high suspicion of SLE associated arthritis. Typically fulfills fewer ACR criteria for the classification of SLE and is more commonly characterized by pulmonary involvement and serositis. So SLE also affects, use the 1997 ACR criteria for the classification of SLE. I think there is a new criteria now. Evaluate for rash, oral, nasal ulcers, non-erosive arthritis, it's non-erosive. Evidence of serositis, cognitive or neurological disorders. There is a history of Zika symptoms that are not medication induced, and history of Raynaud's phenomenon. Initial lab investigations, you are going to check the complete blood count to evaluate for cytopenias. Anemia, thrombocytopenia is extremely classic for SLE. Metabolic panel, check out all the sodium, potassium levels, bicarbonate, blood urea, creatinine. So do a complete investigation and get urine analysis. Why is it important to do an urine analysis? Because SLE manifests as lupus nephritis, which is very dangerous, and we are going to treat them aggressively. Serological testing for anti-neutrophilic antibodies, anti-double stranded DNA, and anti-Smith antibodies. ANA is highly non-specific. You can find in many autoimmune diseases. It's non-specific, but if it is positive, keep an high suspicion for SLE. Anti-double-stranded DNA is specific. So if you get it positive, you have to have a high suspicion for SLE again. In late onset lupus, anti-ribonucleoprotein or anti-Smith antibodies are less likely, because what is anti-ribonucleoprotein associated with? It's associated with mixed connective tissue diseases, and our anti-Smith are less likely. But patients are more frequently positive for rheumatoid factor, anti-neutrophilic antibody, anti-Rho, that's for Sjogren's syndrome, antibodies. Anti-Rho is SSA and anti-La is SSB. How do you distinguish late onset lupus from drug-induced lupus erythematosus? This is often clinically difficult because they have the same symptoms that drug can induce a lupus symptom. So both also have positive ANA on the lab. Although drug-induced lupus erythematosus is associated with a speckled pattern with antihistone antibody. So this is specific, antihistone antibody is specific for our drug-induced lupus. Renal biopsy for patients who have proteinuria or active urine sediment to determine the histopathology before starting treatment. Serological evaluation for the antiphospholipid syndrome for patients with evidence of thromboembolic disease. So this slide is extremely important for us to understand. Renal biopsy, when you have a patient who has proteinuria, is very important. What is biopsy going to show? It's going to show lupus nephritis. When it is lupus nephritis, we are going to aggressively treat with prednisone, cyclophosphamide, and some immunomodulators and suppressants. And you have to evaluate them, screen them every yearly to check how is the progression of nephritis. Also, antiphospholipid antibody syndrome in SLE is extremely important because they may lose the products of conception early on. So second trimester abortion, if anybody comes, 2 of such is one of the criteria to diagnose antiphospholipid antibody. So young lady comes to you and you're suspecting SLE, we have to check for the antiphospholipid antibody, make sure that the product of conception are safe, and they also have high risk of thromboembolic disease. Sometimes they may need lifelong therapy with warfarin and comes adverse effects associated with it. No clinical trials have involved older adults. Short-acting NSAIDs, if tolerated, to treat the arthritis and serositis. So you can use short-acting NSAIDs for the arthritis. Hydroxychloroquine 200 to 400 milligram per day is effective in managing skin and joint manifestation. Macular degeneration is a contraindication. We know hydroxychloroquine causes retinitis. Every 5 years of treatment with hydroxychloroquine, annually, we are going to screen for retinitis. You are going to do a fundoscopy and screen for retinal changes. So that is why macular degeneration is a contraindication. Monitor patients for visual field deficits. Consider low-dose corticosteroids for patients with symptoms refractory to hydroxychloroquine. So your symptoms are not going with hydroxychloroquine, you can give them low-dose corticosteroids. But the most effective for skin and joint is hydroxychloroquine. But significant side effects with long-term steroid use may outweigh the potential benefits. Okay. Now the next slide for management continuation. Depending on the organ system involved and the disease manifestation, methotrexate, azathioprine, mycophenolate mofetil, and cyclosporin, all off-label, can be of benefit as corticosteroid-sparing agents. The safety of these drugs has not been studied specifically in older adults, of course, because they're all recent advances in medicine. We have to have lots of trials to recommend them to older adults. Patients with evidence of antiphospholipid syndrome should receive preventive anticoagulant as warfarin, as well as immunosuppressive therapy. High-dose steroids and cyclophosphamide are reserved for severe neuropsychiatric and renal manifestation of SLE. Okay. Now, going on to Sjogren's syndrome, we said anti-Ro, anti-La are specific for Sjogren's syndrome. Let's see what's the manifestation. This is a systemic, multi-organ chronic disease characterized by lymphocytic infiltration of exocrine glands. May develop alone or in conjunction with other rheumatological diseases, including rheumatoid arthritis, lupus erythematosus, scleroderma, or inflammatory myopathy. Presence of a palpable purpura and C4 hypocomplementemia are potential predictors for the development of lymphoma. So Sjogren's syndrome have a high risk of developing lymphoma. Whenever you find palpable purpura and low C4 levels, that gives us a clue that he may be having a lymphoma. So you have to go and screen him for lymphoma. What is the clinical presentations? The best known manifestations are dry eyes, dry mouth, medical term is xerophthalmia and xerostomia. It's not limited to lacrimal or salivary glands. It may present with dysphagia, difficulty swallowing, painful swallowing, weight loss, vaginal dryness, and sexual discomfort because the body secretions are getting lower and it causes the mucous membrane to dry. May cause extraglandular disease. Now, what's outside the gland? Including renal, bladder, liver, biliary, thyroid, nervous system, and skin manifestation. So you have to consider Sjogren's syndrome in patients with interstitial lung disease, malabsorption, CNS disease that mimics multiple sclerosis, rash, and unexplained renal, liver, or thyroid disease. So we have to check in these patients, like probably it's difficult to analyze right now, but keep a watch out for it. How do you diagnose Sjogren's syndrome? We need to exclude drug-induced sicca symptoms, particularly due to anticholinergic adverse effects. We know cholinergics cause secretion, so anticholinergic reduce it, and you have to exclude one of the cause for it as a drug. Age-related exocrine gland fibrosis or fatty infiltration. So this is known as age-related sicca syndrome. Other connective tissue syndromes. What is shimmer test and slip clamp examination that's used to assess the corneal damage and confirm the presence of keratoconjunctivitis? Now, going on to the lab, we said ANA is mostly used for any autoimmune disease, highly non-specific. Anti-Ro and anti-La, which is SSA and SSB, these are highly specific for our Sjogren's syndrome. And rheumatoid factor is usually positive in such people. Going on to the management. So management is divided based on the symptoms, dry eyes, dry mouth, or inflammatory eye disease. What do you do for dry mouth? Sugar-free candies, easy, right? We are trying to stimulate the secretion. Or you can give artificial saliva. Counsel patients on maintaining good dental health to prevent caries because, first of all, saliva is rich in antibodies and other protective factors, right? So we are going to ask them to maintain a good gum disease hygiene, and the dental erosion also will cause them to have sicca symptoms. So maintain a good oral health. Cholinergic adverse effects limit the use of pilocarpine and cevimeline in older adults. For xerophthalmia, dry eyes, what are we going to do? We are going to prescribe them lubricating ointments, artificial tears. Consider punctal plugs to retain the tears. For inflammatory eye disease, ophthalmic cyclosporin. Cyclosporin is our immunomodulator. Now, the next disease, polymyositis and dermatomyositis. So these are inflammatory muscle diseases, including polymyositis and dermatomyositis from a heterogeneous and uncommon group of skeletal muscle disease. Incidence peaks in adults in their 50s, but these diseases can occur at any age, and up to 20% of the cases are in adults more than 65 years. So 50 to 65, nearing the age of osteoarthritis. So we have to have an eye and watch out for this particular group of diseases. Very important is muscle weakness. So how I remember weakness is itis, because there is inflammation, right? Polymyositis. Okay, I think this has minimal tenderness. That's why they have written muscle tenderness is unusual. Itis inflammation is actually for pain, but this particular group of disease, they have weakness. Muscle weakness is the central feature of polymyositis and dermatomyositis, most predominantly in the proximal muscle group. So lifting the hands up, climbing up the stairs, those are the issues with proximal muscle group weakness. Muscle tenderness is unusual. It should raise suspicion for other conditions. Now, the presentation of the myositis. So they have myalgia associated with muscles and arthritis. When present, it's an inflammatory arthritis and occasionally erosive, suggesting overlap with rheumatoid arthritis. Because osteoarthritis is non-erosive, and this particular age group, we are trying to rule out that because it's around the age of 50. Esophageal dysmotility can cause dysphagia, hoarseness, and aspiration. Arrhythmia, symptoms of congestive heart disease, dyspnea on exertion, or persistent cough suggestive cardiac muscle involvement or coexistent interstitial lung disease. Very important. Pulmonary involvement is a poor prognostic sign. Raynaud's phenomenon or Sjogren's syndrome can be present. Dermatomyositis is characterized by a rash, right? Derma is of the skin. So they have a rash on the skin. Example, like a heliotrope rash on a Gottron papule. Okay. So I think the one of the things that they forgot to mention in the slide is there is a high association with underlying cancer, right? GI-GU cancer. Whenever you diagnose a person with polymyositis, dermatomyositis, we have to screen them for underlying GI-GU cancers. Now, how do we diagnose this? There are many differential diagnoses. So coming to a conclusion, get an endocrine checkup, metabolic, musculoskeletal, medication-related disorders, including our thyroid disorders. As we know, hypothyroid also causes proximal muscle weakness, issues with climbing upstairs. So rule that out. Diabetes affects the nerves and the muscles. Vitamin D deficiency, electrolyte abnormality, particularly hypokalemia associated with potassium abnormalities, polymyalgia rheumatica, and adverse effects from steroids and statins. Steroids also cause this proximal muscle weakness. Rule that out. Statins cause rhabdomyolysis, so that's more dangerous, and yeah, definitely to consider. Initial evaluation, you need to exclude more common causes of muscle weakness like statin use. Serum levels of muscle enzymes like creatinine kinase, aldolase, and sometimes transaminases are very important because these are elevated in this particular myositis, not any other form of myositis. There are few, but this is most characteristic for the myositis, polymyositis and dermatomyositis. Are usually increased in myositis, and normal levels suggest alternative diagnosis. What else we can do to diagnose? Electromyography is used to exclude neuropathy and identify an irritable myopathy. MRI using a fat suppression sequences help to confirm myositis and can help select which muscle to biopsy. So MRI is helping us to get a muscle biopsy. Muscle biopsy remains the gold standard to confirm the diagnosis and distinguish among the subtypes of myositis. So if they ask you what is the next best step, we will tell MRI. If they ask you what is the gold standard to diagnose, is our muscle biopsy. Diagnosis of polymyositis warrants evaluation of cardiac and pulmonary disease. Diagnosis of dermatomyositis and less so with polymyositis warrants high-end suspicion of underlying malignancy. Yeah, recommend age-appropriate cancer screening, especially GI-GU cancers. And polymyositis had underlying evaluation for cardiac and pulmonary disease. Now, how do we manage myositis? Typical initial therapy is oral prednisone, 1 milligram per kg per day. Any autoimmune disease we are targeting with prednisone. Try to taper the total dose by 10 to 20% per month. For severe disease, methylprednisone 1000 milligram IV over 3 consecutive days. When it is severe, you're giving methylprednisone 1000 milligram IV for 3 consecutive days. Methotrexate is used off-label. It's given orally or parenterally in a weekly regimen, can be combined with corticosteroid and can also have a steroid-sparing effect in long-term therapy. You can also give weekly oral methotrexate or mycophenolate mofetil. This is also off-label, can be effective in managing refractory skin manifestation of dermatomyositis. That's our Gotran's papule and heliotrope rash. Okay, so another immunomodulator is our azathioprine, may be favorable alternative in patients with interstitial lung disease or underlying liver disease because it is excreted through kidney. IV immunoglobulin can be effective in refractory dermatomyositis and is generally considered safe, although older adults are at increased risk of renal failure and thrombotic events. So, if they have renal failure and thrombotic events, be careful with IVIG. Supervised exercise has provided beneficial in polymyositis. Okay. So we have next group of disease, fibromyalgia. I'm so surprised to learn that fibromyalgia, so many people suffer from fibromyalgia, underdiagnosed or overdiagnosed. Lots of people have fibromyalgia. It's a pain syndrome that has physical and psychological components. What is the hallmark? Generalized body pain. Can be associated with other complaints such as mood disturbance, fatigue, cognitive disorders, and somatic symptoms. So they may coincide with chronic pain from a variety of sources, including osteoarthritis, neuropathy, and degenerative spinal disease. So if a person comes to you with a degenerative spinal disease like L4, L5 lumbar degenerative spinal disease, and he has a positive leg raise test, so you may miss fibromyalgia thinking that this is because of the degenerative spinal disease that he is having pain, but they may have coexistent fibromyalgia. So keep an eye out for it. How do you diagnose fibromyalgia? Fibromyalgia is a clinical diagnosis. It's made using widespread pain index and symptom severity score, with symptoms present for at least 3 months and no other explanation for the symptoms. Diagnosis no longer includes tender point examination. Aside from generalized soft tissue sensitivity, physical exam should be normal for age. Like pulmonary, GI, you have to rule out. This is a disease of rule out. You have to rule out other signs and symptoms to come to a diagnosis of fibromyalgia. Importantly, patients will not have evidence of inflammation or synovitis on physical exam. Lab abnormalities such as increased ESR or CRP should prompt investigation for an alternative diagnosis. Now, we can treat fibromyalgia in 2 ways. One is pharmacological, other is non-pharmacological. So fibromyalgia is best treated to start with non-pharmacological like physical activity, behavioral therapy. Physical activity, patient education, and cognitive behavioral therapy are the key for symptom relief. When encouraging physical activity, reassure the patient that increased pain on activity is probably temporary, right, and not necessarily harmful. Increase physical activity slowly and in small increments that are easily sustainable. So this is the main cornerstone for fibromyalgia in non-pharmacological therapy. We need to address chronic pain, sleep disturbances, and depression and anxiety individually because they are all coexistent. So there are many studies saying that serotonin is related to fibromyalgia. We know serotonin is related to depression, anxiety. So we have to address those issues in fibromyalgia patients. Critical to form a therapeutic alliance between the physician and a patient, because it's a chronic disease, it's a clinical diagnosis. Patient may be frustrated for an answer to not treat it pharmacologically, right? Because the way for fibromyalgia is physical activity and cognitive behavioral therapy. So we need to form a strong bondage with our patient to have them manage better. Now, going on to the pharmacological treatment for fibromyalgia, we have 3 drugs that are FDA approved. Pregabalin, which acts on GABA receptor, duloxetine on serotonin norepinephrine receptor, and milnacipran. Acetaminophen, anticonvulsants, antidepressants, and weak opioids such as tramadol have not been studied significantly for older adults with fibromyalgia. However, for the younger age group, we could give them. Most medications used to treat fibromyalgia provide only modest benefits despite considerable risk of adverse effects. Individualize the pharmacological therapy based on specific symptoms and reassessed frequently for effectiveness and adverse effects. Because the SNRIs or SSRIs, antidepressants, they all cause GI symptoms, nausea, vomiting, which in every day is really an issue. So when you're trying to treat an elderly for that, first of all, who are suffering from age-related gastric paresis and so on, this could be problematic to treat them with antidepressants or SSRIs. Okay, so moving on to summary of what we studied today. Osteoarthritis is the most common cause of chronic pain among older adults. That's the most common disease. History physical exam remains the most important tool for diagnosing and distinguishing among the rheumatological disease. History and physical exam. When developing treatment plans for older adults with rheumatological disease, keep in mind that each patient's comorbid medical conditions, functional status, and potential for drug disease interactions. Interventions ideally used a multimodal approach, including pharmacologic and non-pharmacological treatment, as well as rehabilitation modalities. We can help them for mobility assisted devices. You can choose any one of them depending upon the issues that they have, crunches, mobility assisted devices. There are lots of them. So you have to ideally go over and help them in leading a balanced life. Now, recommendations based on American Board of Internal Medicine Foundation's Choosing Wisely campaign says that do not test ANA sub-serologies without a positive ANA and a clinical suspicion of immune-mediated disease. So immune-mediated disease, what is your clinical suspicion? Like from history, photosensitivity, or having a previous abortion. So those are all suspicions from the history which will make you go test further. Do not perform MRI of the peripheral joints to routinely monitor inflammatory arthritis, because MRI, you cannot keep on performing all the time. Use biological DMRs only after failure of non-biological DMRs. Non-biological, because biological probably you may trigger the autoimmune condition again, right? So we have to use non-biological DMRs. Do not routinely repeat DEXA scan more than once every 2 years. Okay. So here is a first case. An 80-year-old woman has increasing shoulder pain, profound fatigue, and new left-sided headache. She describes 2 recent episodes, each lasting a few minutes, of a veil falling over her left eye. And in history, polymyalgia rheumatica diagnosed 3 months ago. Initial treatment was prednisone, 15 milligram per day. The dosage was reduced 4 weeks ago to 12.5 milligram per day. On examination, there is no tenderness over the left temporal artery. Fundoscopy reveals pallor of the optic nerve. So, which one of the following is most appropriate next step? Will you resume prednisone 15 milligram per day? Begin methylprednisone 1000 milligram per day IV for 3 days? Obtain biopsy of the temporal artery? or obtain color Doppler ultrasonography of the temporal artery? Do you want me to go to the question? This is the question. 80 years. So whenever we solving this rheumatological question, look at the age group. 80 years. She has increasing shoulder pain. She's profoundly fatigued, new left-sided headache. The second recent episode, each lasting a few minutes, of a whale falling over her left eye. She has been diagnosed with polymyalgia rheumatica and is on prednisone. There is no tenderness of the left temporal artery, and fundoscopy shows pallor of the optic nerve. So what do you guys want to give? Okay. Yeah. So begin methylprednisone 1000 milligram per day IV for 3 days. Thank you for answering, guys. Okay. Now the next case. A 69-year-old woman is seen for follow-up after resolution of a third flare of gout in 9 months. Each of her previous flares responded well to treatment with intra-articular corticosteroid. She has not received uric acid lowering therapy. She has a history of gout, hypertension, diabetes, GERD. On a lab, you will find uric acid level of 8.2 milligram per deciliter, serum creatinine level of 0.8 milligram per deciliter. Okay. In addition to beginning treatment with allopurinol 100 milligram per day, which one of the following is most appropriate? No additional therapy is indicated. Begin oral colchicine 0.6 milligram per day for 6 months. Begin naproxen 250 milligram twice daily for 6 weeks. Begin prednisone 10 milligram per day for 4 weeks. So to go back to the question, she is a 69-year-old woman. She's coming for follow-up after a resolution of third flare of gout in 9 months. And she responded well to the treatment with intra-articular corticoid. She has never received uric acid lowering therapy. She has history of all this: GERD, hypertension, diabetes, and GERD. You have these lab values. Creatinine is good. Uric acid may be good. 8.2 is high or good. So in addition to beginning treatment with allopurinol 100 milligram per day, which one of the following is most appropriate? You are starting allopurinol. What else do we give? Okay. Yeah. Yes. So we will begin oral colchicine 0.6 milligram per day for 6 months. Why? Because she has GERD. See?
Also, you want to avoid a further acute attack. If you are taking any of the uric acid lowering therapies, you have to make sure giving something to prevent that acute gout flare to develop. So colchicine will help you prevent that gout attack, and allopurinol will help you to prevent developing in future.
Right. Yeah. So my answer was for yeah. Thank you so much, Sobia. Yeah, I was answering why naproxen is not the answer, because in history she has GERD. Yeah, that's going to aggravate GERD. Yeah. And as you said, that's going to prevent. Correct. Thank you so much, Sobia. Okay. All right. So you're going to begin oral colchicine along with allopurinol. That's awesome. Okay. Now the third case. A 79-year-old woman has aching pain in her shoulders, hips, hands that began several days ago. She has morning stiffness that lasts for about 1 hour. She feels fatigued. She has had no joint swelling, weight loss, fever, headache, trouble chewing, swallowing, or change in vision, none of which are there. Lab studies are pending for ESR, CRP, rheumatoid factor, anti-CCP, and TSH. So this is a 79-year-old woman. She has aching pain in the shoulder, hip, and hands, okay? Several days ago. Morning stiffness that lasts about 1 hour, and she is fatigued. There is nothing, no joint swelling or anything, and labs are still pending. Which one of the following would be the most appropriate treatment while awaiting lab results? Will you give her prednisone 15 mg or 60 mg or naproxen 500 mg twice daily or methotrexate 10 milligram weekly? Until her lab results come, you're not finding anything in the examination, labs are pending, and that lasts about an hour, and she feels fatigue. She's a 79-year-old woman. Where is the pain? In her shoulder, hips, and hands. That began several days ago. Okay, let's go for the answer. Okay. So you are going to give her prednisone 15 mg per day, probably because this is last for about an hour and she feels fatigue. That's one of the clue to say in the history that it's an immunological disorder. Yeah. Okay. So these were the slides, presenters, editors. It was edited by Daniel Sinderman, MD, CMD. Chapter authors are Una E. Macris, MD, MSc, Emily Bowen, MD. Questions author was by Rashmi Kadilkar, MD. Managing editor, Andrea Sherman. Thank you so much. These are amazing slides, Dr. Nadir.
Thank you so much, Rashmi, Dr. Sobia. This is great, excellent work, excellent presentation. Thank you so much. So
You're welcome.
Any questions or any comments from the other group? Fellows? Awesome. Great. Thank you so much again. So in geriatric, yes, we go over all this, like history is important when taking when you see your patients as well as the exam. So most of the time you can get some cues from these two. Then the lab or X-rays or other images will help you just to confirm your thoughts. So this is great. Excellent. The other thing to remember is before we prescribe any medication, just think about what the individual in front of you has, like what comorbid conditions. If they have renal issues, then you don't consider NSAIDs. If they have liver condition, avoid Tylenol and such. If they have other medication they are on, then you need to think about drug-drug interaction and try to avoid any side effects that can happen. Because we don't want to solve the problem and create another problem. Because let's say you prescribe something for the patient, you solve the pain issue, but they end up with nausea, vomiting. Then what you're gonna do? You're gonna give them something for nausea, vomiting. Then they will end up with skin or sleep problem. So it's going to be cascade issue. So you think about do no harm first for your approach. Thank you so much, everyone, guys. So for next part of the agenda, let me see. We are getting for Sumi. She will join us shortly. In the meantime, I'm going to share with you two topics. One of them is another tool for statistics. It's called R tool or R Studio. You can use it. There are two versions. One version you can download it into your computer. It's like SPSS, and you set up, install that program, and use it in your PC or Apple MacBook. But they have another option, which is an online, like a cloud version of the same program, which is very, very useful. Initially, it may need you to learn a little bit of the basics, but it's very effective, very robust, and it can help you do a lot of things, and it's free. So there are more advantage using this tool compared to other statistical available tools. You can use, for example, Excel, but it's very limited in the statistic methods. You can use Google Sheets. Also, it's limited. If you need to have different ways of using statistical method, then this might be an option for you. So if you go to the RStudio.cloud, here you will have options. One of them is they have the cloud guide, they have the studio, you can log into that. They have some packages that you can add to your program. So different packages according to what you want to do. All this can be added to the basic software. You can start with the basics. They have some free courses. So if you click on the basic, they go over how you, if you want to, let's say, install the program and go up the steps, you can do that. Or if you want to do it online, also they can go over that. So for me, I want to log in. Let's say I want to. You can use Google account, for instance, just to log in. Let's say yes. So it will land on this worksheet for you, and this you can use a new project. If you click here, you can, if you want to start a new project, it's gonna be free area where you want to build up your things. For instance, if you want to obtain the data from, let's say, an Excel sheet, you already have some data. You can import this data, similar to SPSS. You can import some files. At the beginning, it might be a little bit intimidating because it's kind of programming language, but they can show you how you can go over this slowly. So there is a blog that's done a few years ago by John Lam. That's basically going over the history of what the R tool and how they can use it. And they have a reference for the like YouTube video, 13 minutes. And if you have some time, you can view that, watch that video. But for instance, they go over a quick tour, what you can do. They can start from the very basic. So if you type 3 + 4, it's like the calculator, it will give you the output as 7. But you can import some data. Let's say you have some information saved in a file online. That file you can import instead of, most of the time what we do, we download the file and then we can upload it or use it in SPSS or Google Sheet, for instance. But here you can import all these files online and save it in a readable file in your cloud studio. You can name that file. So to do that, you can do just 2 words. You put the name of the file that you want to boot as outcome, and you put this file, and then read. It's a PDF file, which is like a data separated by comma. It's comma separated variable. This data located in this area, and then use it as a string. So when we get the information, if we open that file, it will have some information with all the data from that online file. To work on this, let's say we want to clean it, we want to put it in a table format, so you can move the data into a table format, and then you can put the names of each column. So each row will have one variable for one object. Let's say in this case, the airport in the United States. Here we have 1,600 or 1,700 airports in the US. So they will have the city, the name of the airport, the latitude, longitude, and altitude of that airport, and the FAA number or code for that airport. And we can use it for instance, if we have a big data set for patients information, like if they have multiple comorbid conditions, if they have diabetes, hypertension, whatever, you will have a big data set, and then you will each line will have the patient name and then the identification, and then you will have more data about the medical conditions or medication they are taking. But if you want to limit, let's say you want to limit your data to a specific disease in this condition, they want to limit the airport out of this 1,600, 1,700 airport in the data set. They want to locate only the airport in your area or in your city. So we'll have 13 airports in your area, and we use this very simple one-line kind of syntax or way to let R limit or filter the data to be only for New York. Then, if we want to locate it by altitude, we can also further filter it down to that. So we have 7 entries. If we want to plot that into a map, there is another package that you can add. It's called Leaflet Library to the program, and that package will help you create the map with the data that you have. Let's say I have this table. I want to locate all this on a map. So you will have the map, and then each one of these is one airport. If you click on it, it will pop up the name of the airport, which is this column. So there are different libraries or packages that you can add to the program according to what you want to do. It's a free product for the simple task, but for more advanced ways of analyzing data in big companies, let's say IBM or Google or other Microsoft Office Excel, they can use it, but they have to pay basically for big data management. But for us, we can use it for the simple statistical analysis that we need. Basically, we use for, let's say, research project if you are doing an experiment or doing some topics. So it's an easy one to use. It's straightforward. Initially, it might be intimidating as far as what you need to do, but they have a help section, and they have a lot of videos. They have the tutorial. You can go over the tutorial, the basics. They will do basic things for you, like if you want to start from scratch, they can continue everything. How to add the package to your tutorial, how to write the first syntax, and how to plot, for example. We spoke about other graphs. They can create some graphs here. Any questions so far as far as tool for analysis? I know, I think one of the fellows, I don't think she's present, or she's present here. She already has experience and she worked with some companies using our tool. It's a good thing to know about and to practice in the future if you are involved in big data set for analysis purposes. As I said, it's free, it's very effective, and it's an online. They have the studio online version. You can use that. If you want to download it and install it in your computer, also that's an option. You can add packages or libraries to the tool that you're using, so it can be expanded or branched to what area you want to work on specifically. So if no questions, we can move on to next topic in the agenda. So for next part, I want to share with you some of the new advances in medicine and in technology. And specifically, I want to share with you artificial intelligence. So one of the studies that we did in the past about COVID, we thought maybe we can also apply the same concept that we are going to talk about as far as artificial intelligence. So if you can use the chat box, let me know if you have any idea about the artificial intelligence, or perhaps you used it today or in the last few days or weeks. Can anyone just by show of hands if you use it or no, something about it? Go ahead with the chat. So we'll talk about it then. It's the history behind it goes back several decades ago. We'll go over some of the details, but it is used every day. So now if you are using Google, for instance, you are using the map, for instance, to drive from one place to another, the GPS mapping when you drive. All this built on artificial intelligence. Using Google, if you are asking questions, it's built on artificial intelligence. If you are using Twitter, Facebook, any type of social media, online stuff, most of it are built on artificial intelligence. So let's talk about it. We'll go over the definitions and then explain some of the history and maybe some of the modern use of it. So, there are different definitions, but the basic one is artificial intelligence is a branch of computer science dealing with simulation of intelligent behavior using the computers. So basically the idea is to build a program or a machine that will do things according to the behaviors that as the human beings do things. So basically it's thought as a program that can sense or reason, act or adapt to achieve certain goals or tasks. There are other definitions, but we can go over the big one. It's just the capacity. The intelligence is the capacity to learn and solve problems. So if we have an issue, we want to tackle that issue, issue or problem, then we can use our own brain to come up with a solution, or maybe we can ask the computer for help. So these are the steps that the computer basically try to simulate and come up with solutions or reasoning. We start in the 50s, maybe before that, but next is they coined the term artificial intelligence as far as using the computer programming to simulate or follow so that it can solve some problems. It became faster and faster, used more in the 80s, and then last 2 decades, it flourished. There are different sections or layers of the term or the use of the artificial intelligence. The global or the big one is just the reasoning or sensing or adapting, what we just call, we talk about, but there are more into detailed layers. One of them is the machine learning, where they use certain algorithms to perform the task, or maybe to use certain data to improve their performance. One example is in the 80s, let's say they developed the robots. They want them to walk, so they want them to calculate their movement, and each time they stand up and do the first step, some of the robots will fall down. So they want them to calculate which movement help them to stand and which one cause them to fall down. And calculating these movements of their joints, they can do some algorithm to delete or to avoid certain movement and to recognize and improve on, build on certain movement. And further studies done with this to improve the ability of the robot to walk or jump or flip. Not only that, but they can look at other robots. So they put them into areas where they can see what other robots can move and adapt or follow this movement that makes them walk better and avoid anything that the other robot did, like cause them to fall down. So it kind of pick the best option and delete the rest, similar to what you went through, like you can use step 1, step 2, but the best answer and on your question. So you want to make sure each time you practice, you will improve your exam ability and performance. The last part is deep learning, where the machine itself will use networking and collect a lot of data from different resources and then analyze this data and try to learn and then change their behavior or task or whatever they want to do. So this is where the deep learning go into space. Like we can go over some of the machine learning, for example, emails. You can use your email. Most of the emails, they have a filter where they can label some of the emails that you get as spam, and some will leave them alone to go into your inbox. So you can say, oh, I don't want to look at these spams email, I'm just gonna delete them. Or maybe you can open them and say one is not a spam, you put it into your inbox or archive that. So the machine will learn your behavior as far as which one you said it's spam, which one you said it's not spam. So the next time that person or company send you something into your email, it will recognize your behavior before, and then depending on that, it will filter or branch out the incoming emails. We can teach the computer to recognize face, for example, face recognition or animal. So we give them some photos, and then using these photos, we can teach the computer. This is several years ago. They looked at how the computer can recognize a cat from a dog, for instance. Or translation. Let's say nowadays you can use Google Translation instantly. In the past, they have to work on getting this done using certain techniques. But now we can use it, and I'm going to show you in a second how we can do that. There are positive pros as far as what the use of AI, but also there is a chance of using it with negative feedback or negative things like harmful to the society. So there are certain positive aspects for the, let's say, the robot can use the artificial intelligence to do tasks, let's say in factories. If a factory wants to build up a car or paint the car, the robot can do that fast, and the line can happen. So automatically or autonomously, let's say, and the robot can do certain tasks that you program the robot to do, and they can find their own algorithm to improve or do the job with some enhancement. We can use it, let's say, in gaming, but we can use it in medicine. There are different ways that we use artificial intelligence in medicine. There are different branches, different areas where artificial intelligence can be applied to in the field of cardiology, for instance, neurology, or radiology. So you give the machine the X-ray, and it will recognize if there is a lesion, for instance. I used to work in a lab where we look at CT scan or MRI of the brain for patients with MS. So the lesions we used to mark it down by hand and calculate like how much is the volume for certain patients. And depending on that, we can say, oh, we can use some treatment, and then we follow them in 6 months or 1 year and see if that treatment is working as far as the dimension or the volume of that lesion. If it decreases, that means maybe the drug is working. So we can now use the machine to recognize that and then tell us, yes, there is improvement according to the medication that you are using, or maybe the drug is not working. It can be used, as I mentioned earlier, in telecommunication companies. So, for instance, nowadays, if you browse any of the social media, let's say Facebook, it will recognize your pattern or your way of thinking, your likes and dislikes, and the company can use all this information to push or display some advertisement for certain products. Let's say you are looking at shoes. So next time you open Facebook, it will pop up with some advertisement regarding the new shoes model or whatever company that's in the market. So it reads your behaviors and likes, and then build on that, and they can modify that. Not only this, but let's say you are driving by certain area, your phone will communicate to that company that you are driving in this area. Then your let's say the company work in that area, let's say Facebook in that area, will pop up certain places near you. It's called fencing, where you will look at it. Let's say you are driving from Michigan to New York, you come across Ohio in certain area. So your phone will be able to populate, if you open Facebook in that area, with all the, let's say, drive-through McDonald's or whatever company that will sell you their food if you're hungry. So, and depending on your behavior in the past, how many times you went to this restaurant and or that fast food chain. Now, going back to the robot, they developed this almost human being feature called Sobia, and funny enough, Saudi Arabia get it the citizenship. So that's several years ago. But there are different robots and different ways of doing things, ranging from tiny bit of, let's say, insect size or animals, dolphin-like or snake-like, to things that fly, bird or something, or human-like or animal-like, like a robot that will carry heavy stuff, put it in places, or sort out things like for the mail, for example, when you send packages, that can work on that. So the future here for artificial intelligence in medicine, we need to use it more and more in cancer patients, in developing of new drugs, in combating, let's say, pandemic like COVID. We can obtain more information and we can use it for our advantage. There are some advantage for artificial intelligence as well as disadvantage. So it's powerful. The computer can learn, can improve, and can do things fast, can solve problems, but it can erase some of the jobs that people, for example, are doing now. In the future will not be done by humans. And the cost might be high initially. Software and development of brief and the risk of malware, where the hacking might happen. So, in conclusion, artificial intelligence is an important part. It's used in different companies or fields. Medicine is one of them, and we need to think about it in our future as physicians. And these are some of the references. So if I want to share with you one thing, I'm gonna try to stop sharing and then find the other one. So, for example, if I want to share with you the basic information, let's say Siri on your iPhone or Google on your iPhone, if you tell them to translate something from English to Spanish, you can do that online. Google has translation, translate in Google. It has two pane or boxes where I say welcome in English and Spanish to be the same. But if I want to say I am teaching today. This is how you say it in Spanish or write it. You can listen to that voice. But I can do the same using Google Sheet. So if I want to start a new sheet, I can just write this, go here, and then I need to give the computer an input. In this case, it's going to be a text, and I want the computer to give me an output, and it's going to be also a text. It could be a voice, an image, or whatever. So I want to say the same thing. Let's say I am teaching today. So if you write that, the computer will recognize this language is in English, or maybe you can tell the computer that in English, but the output I want it to be in Spanish. So to do that, I can just add the equal sign and then translate. And the text will be here, and in English to Spanish, I think. In the past, it used to work, maybe Google removed it. But basically, you will say translate, and you put the text, and it will give you the output here. Let's say, for some reason, it's not working today. But this is how you build up your language of the program for the computer, and it will recognize that you are talking in English and the output you want is in Spanish. Let's see if I can find it. Oh, the syntax is Google Translate, sorry. So my mistake. So if you type Google Translate, you need the first text, which is I'm going to, let's say, teach today. And then the English is the language, and then here is the Spanish language. If you click enter, it will load and it will do the same for you. And I can do the same. Let's say this is Spanish. I want to do it in Arabic, for example. So I'll just AR for Arabic, and it will load it. English to French, for example. So, no, let's say Arabic, but I want A1, A2. So, this is how it will show you. So, this makes sense now. So, you can build your own way of thinking. The machine needs some input, and then you tell the machine what kind of output you want, and the machine will do that for you. This is what Siri does. Let's say you can ask Siri, what's the weather today? So when you say what's the weather today, this is the input. The output, Siri will look into the weather in your area, your location, and then it will put it in a text, and then from the text, it will read it aloud for you as an output for you. So all this built in artificial intelligence way of doing things. So this is just an introduction for you guys. There are a lot of videos about artificial intelligence. There are a lot of slide presentation. Later on, maybe we can dive into a specific area or a specific way people are using artificial intelligence in that sense, what they use for certain condition or certain problem to be solved. Thank you. Any questions, any comments? So my question for you, when I asked you before we talk about intelligence, so all of you are using smartphone. I take it smartphones or using your computer, your laptop, your mobile. So all these devices, they have built-in artificial intelligence, whether you like it or not. All the information you are using, browsing, emailing, texting, WhatsApp, all this will be collected somehow, and they will be analyzed, and you will be used as a client or customer to show you some certain aspects of your behaviors, your likes and dislikes. So it's useful for you. Let's say I want to drive from here to the university, then it's going to be helpful. Any question? Any comments as far as the last two topics? If not, let's go to the last topic, or the updates of the. Do we have any updates as far as the project, guys? Any? So someone asked about how we can use it in research. So we have a lot of data that we can use. We can write, let's say, some articles. You don't have to do it as a research work. You can just actually there is some. I can share with you this one, for instance. You can use it to manage or look at data from different studies done. It's a funny story. Someone wrote a whole article using artificial intelligence in the past. It's just how you write the algorithm for that program. But let's go to the subject. I'm going to share with you here. So here's an article that's about brain training using games to enhance cognitive functioning of the adult. So this study was done in Saudi Arabia. They are using software or an app that people nowadays use to help enhance the brain activity or cognitive activity. It's called Rheumatology or Rheumatology. So that app is developed and is used by many clients or customers or patients or subjects. This app can be used similar to what Google is doing, or let's say Facebook is doing. When you enter your information, they will collect this information, and then they will help you, let's say, give you a game where you will enhance your brain. But at the same time, they will know your behaviors, and then they can use it in the future as far as how they can help you. For instance, let's say you have difficulty in achieving certain tasks. That app can do some similar to a mental state exam, and can identify areas where you think or the program thinks that you have impairment or deficiency. Let's say your score is supposed to be 27 or more, is 23 or 22. Then they will say, oh, this area needs to be addressed. Maybe it's better to see a neurologist or psychiatrist to evaluate you more. So they can look at your location. Let's say you are in Ohio, they will locate where neurologists in your area are available who are treating patients with an cognitive problem. They will put you a list, they will give you a list, and then you can say, oh, I want to make an appointment. So you go to your family doctor or primary doctor and say, I think I have problem with my cognition. Can you refer me to this whatever physician, neurologist in the area? And they can do that. If I answer the question. Thank you. Any other comments or questions, guys? If not, let's jump to the update as far as projects. Anyone with any comments, guys, or questions or updates?
Hi, Dr. Nader. I hope you're doing good. I finished my step 3, and thank you for giving me the chance. Thank you for letting me not attend the meetings. And I want to update regarding one of my projects regarding the webinar on the vaccine efficacy in heart failure and heart transplant patients. I got all the PowerPoint presentation slides from our team members, and we would like to present it to you whenever possible and get the feedback from you and accordingly edit the slides and plan for our webinar date.
Excellent, excellent. So I will be in touch with you guys. And did you practice as far as each one who will be presenting what?
Okay.
Or not yet? If not yet, so what I prefer to do, you can use the tool that the coach, Microsoft PowerPoint coach. Can you hold on just a second? Sorry about that. So if each one of you guys can present using that, record and see how many minutes you can do your presentation, and if there is anything that you want to improve on, and then we can put all together and we can do it either within the group and myself, do it that way, or perhaps you can present it in this meeting, during the meeting, and everyone will give you a feedback time. So in the past, I think we did it in a separate meeting, and then we went ahead and presented to the public. So talk to your team, see whichever you prefer. We can do it in a separate meeting. We can the small group, or if you want, we can also present it to these fellows in our coming meetings. You can and then separate reserve some time for that. Thank you so much for the update.
Sure. I will talk to the team and then update you. Another question is that we were planning to split the team into two groups. One group will be presenting in English and the other group will be presenting in Arabic. So.
So in 2 languages, you mean?
Yeah.
Perfect. That's also awesome. So it will be 2 days, different days, and the slide of the flyer will be also. So that would be great. Thank you.
Okay. Yeah. Thank you so much, Dr. Nader.
We'll
get back to you.
Okay, I'll be in touch then.
Yeah.
Anyone else? Thanks for that. If anyone else wants to update, I know some of you are busy doing the steps, especially step 3, and congratulations to those who have done it. If you're still working on getting your step 3, you might be excused as part of the meeting. Just reach out to your team leader, tell them that you're busy, you're not going to be able to participate, and you are allowed to focus on your exam because it's important. As far as the ERAS application, if you need still letter of recommendations, please let me know. I also want to share with you, next week we're going to start the grand rounds at Sparrow. It's going to be every 2 weeks on Tuesday days, 12 noon to 1 o'clock Eastern time, New York time. So if you can attend, that would be great. If you prefer, I'm going to share with you. It's in the app. When you go to the app menu here, you go down, select at the end, you will have the schedule. The first countdown will be on the 13th. Also, next this week, there is Utah University. They have presentation. So if you click here, it will give you more information as far as clicking to join the meeting. It will be 8 in the morning Mountain Time for those who are interested. I think in the coming weeks also we'll have some neuro rounds for those who are interested in neurology. I didn't get the schedule yet. Whenever I get it, I will update the app here so that you can just click on it and see the link. Usually they start at 7:30 in the morning Eastern time, and at the end of the meeting they have also some cases for those who are interested in neurology. Okay. If no other questions, I'm going to share with you next week's agenda. This is this week. Next week we will have the red team. If the team can reach, I'm not sure who's the leader now, but one of the leaders can go over the agenda. And again, if any of these names are able to present, that would be great. If they have any obligations, otherwise, let your team leader know so that they can assign someone else. If the whole team or most of them are preparing, let's say, for step 3, anyone of the other teams, they can approach the team leader so that they can have the opportunity to present. The dentist, they will be presenting some topics. So Dr. Mayara, if she is with us today or someone can reach to her, she can pick up a topic we have a list of items, one of them, and she can present. If she is unable for some reason, maybe she can let the other dentist, one of them might step up and present their topic during next week, and we can do that for the coming meetings. Let me see if Sumi is here. So we were waiting for Sumi, but for some reason she did not join. So hopefully she can join us in the coming weeks, and we'll have some views or tips or advice from other fellows who join the programs. I know some of you might be interested in geriatrics, some might be interested in other areas. For those who are interested in geriatrics, I think if you have passed step 3, if you have the citizenship or green card, and if you have some clinical experience, even if it's overseas, I think there are certain programs that can accept you for geriatric fellowship. So think about it as plan B in your mind. Apply to the programs that you are interested in medicine, family, or neurology, or any other, and hopefully you match all of you. Just in case you don't, then think about applying to these fellowships. In the past, some of the fellows got accepted to geriatric fellowships, and some, I think one got accepted to nephrology fellowship. So think about it down the road. All right. If you have no more questions or comments, I'd like to thank the presenters for today, Ashwini and Sobia, and I'd like to thank all the fellows who attended today, and for those who didn't, you can review the recording. And we'll see you next week. Thank you so much. Have a wonderful day. If there is any questions, you can stay later. Otherwise, have a good, wonderful day, guys.
Thank you,
Dr.
Nader. Thank you so
Thank
much.
you.
Thank you so much, Dr. Nader.
Thank you so
Thank
much.
you. Appreciate it. Thank you.
Thank you, Dr. Nader. Bye-bye.
Thank you. Bye. Have a wonderful day.
Thank
Bye.
you. Thank you so much.
Thank you, Masalama. Thank you so much.
Thank you.
Thank you. Have a great day.
Assalamualaikum.
Assalamualaikum, Dr. Nader.
Thank you, Dr. Nader. Have a great day.
Thank you, Dr. Nader.
Thank you so much, everyone. Assalamualaikum. Mayada, go ahead.
Yes, doctor. Assalamu alaikum.
Alaikum salam. How are you?
I'm fine, thank you. And you?
Very good, thank you.
Yeah, just I wanted to ask you regarding dentist topic. Do you have a specific topic I have to choose, or I decide?
So, mentally, this, I think, 5 topics or 6 topics.
Yes, she asked us. Yeah, we share together the topics.
Yes.
So I choose some of them.
Yeah,
one of them.
One of them, and then you can ask the other fellows to pick, so that each one has at least some topic in mind, so they can prepare. And if you let me know, I can update the app, or you can do that.
Okay, sure. So I will shoot you an email in coming days. Yeah, regarding the topics. Okay, thank you, doctor.
Thank you so much. Have a wonderful one.
You too. Thank you.
Assalamualaikum, everyone.